Good morning, good afternoon, and good evening, everyone, and welcome to this Scientist.com and BioModels webinar titled Preclinical Animal Models of IBD, GvHD, and Pulmonary Disease. I'm Andrew Davies from the events team here at Scientist.com, and I'll be your host today. We're very fortunate to be joined by Dr. Andrew Borkowski, Principal Scientist, and Dr. Nicole Smith, Senior Scientist 2 at BioModels, who will discuss preclinical models of inflammatory disease, including acute lung injury, asthma, Crohn's disease, ulcerative colitis, and graft versus host disease. Before I welcome our first speaker to the floor, I just wanted to cover a few brief housekeeping notes to help you get the most out of your experience. First, this webinar is being recorded and will be available to view on demand shortly after the live event. Next, if you take a look at the interactivity panel on the right-hand side of your screen, there are 4 tabs corresponding to chat, Q&A, polls, and handouts. If you experience any technical issues, please first try refreshing your browser, as this fixes most problems. But if you're still having trouble, please reach out using the private chat function and we'll help you to troubleshoot. We'd also love to hear from you, so please send any questions, thoughts, and comments using the Q&A tab at any time during today's presentation. And finally, you can also explore relevant resources in the Handouts tab to learn more about some of the content presented today. And with that, it is my pleasure to welcome our first speaker, Dr. Andrew Borkowski. Thanks so much for joining us today, Andrew, and please take it away whenever you're ready.
Good morning, and thank you for joining us today. My name is Andrew Borkowski, and today with my colleague Nicole Smith, we'll be talking to you about preclinical animal models of inflammatory bowel disease, graft versus host disease, and pulmonary disease. I'd first like to tell you a little bit about our company. We are BioModels. We're a preclinical contract research organization located just outside of Boston in Waltham, Massachusetts. We were founded in 1997 out of Brigham and Women's Hospital, and we focus on highly translational models of human diseases and conditions for a wide variety of clients. We focus on a number of disease indications, including inflammation and autoimmunity, pulmonary disease, fibrosis, microbiome, oncology, as well as cancer supportive care. We also enjoy setting up custom models and validating models found in the literature. And we're happy to announce that we facilitated over 100 plus compounds into patients across multiple indications. I'd also like to take this opportunity to introduce our new brand identity. After 25 years in the industry, we're excited to share that next week we're launching our new website to align with our new branding, Mission Critical Science. Mission Critical is a powerful phrase, and that's why we're using it. We know these experiments can make or break a drug moving forward into the next phase of development, and as your CRO partner, we're here to provide you with good science, high standards, and quality data. One of the ways that we're able to do this is through our personalized service. We prioritize working with our clients to create a study design that perfectly aligns with their experimental goals and what answers they're looking for. For many of our clients, utilizing an already established model will yield the data they need, whereas for others, we collaborate to create a custom solution based on their specific hypothesis. A core component of our mission is to provide you with clinically relevant and highly translational models of human disease. When we talk about translational disease, there are a number of things that we look for. Will this model replicate the clinical condition? We focus on models in which the underlying biology should be the same or very similar to what is seen in the human condition. Ideally, this model will be cost-effective and provide actionable information. Additionally, endpoints should be translatable to those used in clinical trials. So today we're going to focus on 4 disease areas, though we offer a number of other disease models outside this area as well. I'll start talking about graft versus host disease, followed by allergic asthma and acute lung injury models, and my colleague Nicole will speak more on inflammatory bowel disease and colitis models. So as a brief overview of the talk today, we'll first provide disease introductions of graft versus host disease and pulmonary disease. We'll then give specific examples of study designs as well as disease progression, and then show some data with some of the standard endpoints in these disease models. So the first disease I'll be talking about today is graft versus host disease. So this is a disease in which cells from the graft will attack healthy tissue in the host. In this disease, patients undergoing allogeneic hematopoietic stem cell transplant are at risk. We see about 80% of these patients showing signs of acute GvHD within 2 weeks of transplant. Additionally, 30 to 70% of these patients develop chronic GvHD, and GvHD is the leading cause of death in these survivors. We know that graft versus host disease is highly dependent upon T cells originating in the graft and can affect multiple organs within the body. We have a number of graft versus host disease models, but they all follow similar disease induction. We typically start with a host animal and transplant bone marrow, which is often supplemented with T lymphocytes or splenocytes, into an MHC mismatch host. We know that disease severity is highly dependent on the presence of the T cells within that cell transfer. Additionally, prior to this transfer, a host will be preconditioned to enhance the engraftment. There are a number of metrics that we assess graft versus host disease within these animal disease models. One being survival, another being weight change, and the final being a 5-component GvHD score. Animals can receive a maximum score of 10 based on 5 different criteria. The criteria being weight loss, activity, posture, fur texture, as well as skin integrity, each graded from 0 to 2 with increasing severity. The first component, weight loss, is based on the percent weight change seen during the course of the disease. A naive animal typically won't show much weight loss, but will still receive a score of 0 up till about 10% weight loss. A score of 1 will then be assigned between 10 and 25% weight loss, and then the final most severe grade of grade 2 will be assigned following 25% weight loss. The next criteria, activity. As animals get sicker, we'll display decreased activity, and we'll see progression throughout the course of the disease. Posture is another component of the GvHD score, and as animals progress through disease, we first see hunching posture and then a more severe impaired gait. Changes in fur texture can also be observed during disease and range from both a normal clean coat to a very highly ruffled coat. Finally, as disease severity worsens, we see more effect on the skin integrity score. So initially, we may see some scaling of the paws and tail, but this usually advances to obvious denuded areas of skin. So today we're going to be focusing on 3 different GvHD models that we run here at BioModels. One being an acute major mismatch model, another being a chronic minor HA mismatch model, and the final model I'll present data on today is from a human PBMC xenograft GvHD model. As I kind of went over, here's a list of some of the standard readouts as well as additional readouts that we offer for the model. We're always happy to collaborate on new endpoints, so if you don't see something here that you're interested in, we'd be happy to discuss anything further. So the first set of data that I'll be presenting today will be from the acute GvHD model, which is a major MHC mismatch model. I'd first like to present an example study design showing a number of control groups that we often run in these studies. Any treatment groups with your test compounds would be in addition to this. So with every study, we run a small naive group to establish a baseline for scoring, weight change, and survival. We then have a disease group that is treated with vehicle, as well as a reference compound treated group. In this model, on day -1, we'll first give a total body irradiation, a lethal dose of 8 gray, and then on the following day, provide the cell transfer from MHC mismatched animals. Over the course of the study, we then can start a treatment, and we typically start treatments around day 14 as this is considered the start of the disease. Endpoints can be taken anytime throughout the study, but in a typical study, we typically run out to day 56, looking at survival, weight change, and graft versus host disease component score. We often take collections for further analysis as well. So I'm now going to go through some typical data for this MHC mismatch model. The data that I'll be presenting today, all of the groups were given a total body irradiation and then a cell transfer with bone marrow. The differences between groups are the number of splenocytes that were given, as well as the reference compound. So in the first three groups here, they were either given no splenocytes, 1 million splenocytes, or 2 million splenocytes. And with the standard disease run, they shall receive 2 million splenocytes. And then the final group here is the standard model plus a reference compound. So by day 56, we typically see about 50% survival. And as you can see, as you decrease the amount of splenocytes, you see increased levels of survival. Additionally, with the reference compound, you see a pretty substantial effect on survival. The next piece of data that I'll go through is body weight change. So focusing on the standard diseased animals, we often see a sharp decline in weight, and this results from the total body radiation and gut toxicity that is observed following that procedure. We then see pretty sharp weight recovery to day 14, and then after day 14, more of a progressive weight loss. So during this time where the animals are recovering from the gut toxicity, the cells from the cell transfer also engrafting, and so we don't typically see clinical signs of disease until about day 14, and why we consider that the start of disease. Treatments are typically begun around day 14 at that point. So within the weight loss data, you can also see a dose-dependent change in weight based on the number of splenocytes, and here we see a mild beneficial effect of the reference compound. The next piece of data, the composite GvHD score, we see trends that are basically an inverse of what we see with the weight change. Initially, we see sharp increases in the GvHD score, and this typically mirrors weight loss and then some of the other changes in the other component scores. This then usually returns to baseline by day 14, and from that point on, we see progressive increases in the composite GvHD score. As you can see here, we also see dose-dependent changes on this composite GvHD score based on the number of splenocytes that were given in the cell transfer. And with this particular reference compound, we don't see any obvious benefit to the model. So typically when we are assessing efficacy in these models, we take into account these three metrics for determining how well this may have impacted disease severity. There are a number of other endpoints we can look at as well, and I'll get into these in the next couple slides. So we often look at histology of different tissues within this model. So in this particular set of data, we're looking at oral mucosa in three different groups of animals. So in the first group here, we have naive tissue. The second group is early disease tissue. And then the third group here is a more severe disease tissue. So when this tissue was scored for lymphocyte infiltration, we see progressively increased levels of disease in the more severe graft-versus-host disease animals. Additionally, we often look at intestinal inflammation within this model. And so as you can see, as disease progresses, we see increasing endoscopy scores. We also see significant increases in diarrhea, as well as significant increases in colon weight length ratio, as well as jejunum weight length ratio. So I'm next going to speak on the chronic GvHD model that we run. So this is a minor HA mismatch model and has more of a sclerodermatous phenotype. So the disease setup is very similar to that of the acute model, except we use different host and donor animals that only have a minor HA mismatch. This model is not as penetrant or severe in terms of mortality, but we are able to look at a lot more animals, typically tissue in these animals at the end of the model. So minor differences here within the model. We have a higher TBI dose with these black 6 host animals. Induction's very similar in terms of cell transfer. And then the other difference is that we typically recommend treatment start around day 21, as that's normally when we see increases in clinical disease. So as I mentioned, survival is usually a bit better in this model. We typically expect around 70 to 80% survival by day 56. In this particular study, we had a 3-group study of naive, diseased, as well as diseased ruxolitinib-treated animals. And as you can see, both the naive and ruxolitinib-treated animals had 100% survival by day 56. Looking at the weight change here, you can see that it's a little bit different than what we saw in the acute model. The animals here don't typically lose weight following total body irradiation. And while the naive animals gain a good amount of weight over the course of the study, we can typically see mild to moderate weight loss in the diseased animals. And as you can see here, we only see mild benefits with ruxolitinib treatment. Next here, we're looking at a composite GvHD score. And so for this model, we use a different scale when scoring disease. This provides a little bit more granularity to the sclerodermatous phenotype that accompanies this model. So instead of a max score of 10, we have a max score of 18 for this study. And the scale in each component is a little bit higher to provide a little bit more granularity when assessing treatments. So as you can see here, based on the clinical scoring, disease becomes progressively worse following day 21. And as you can see here, ruxolitinib provides a pretty substantial decrease in that scoring. Another piece of data that we provide with this model is a progression-free survival graph. And progression-free survival is in any animal that has a score increase of 2 or less following the start of treatment. So as soon as an animal has a score that's increased by 3 or more following the start of treatment, this animal is no longer going through progression-free survival and is starting to show progressive signs of disease. So as you can see here, while we end up kind of in the same place with both ruxolitinib and vehicle-treated animals, we see that there was a delay in kind of onset of disease with this reference compound. So finally, I'd like to speak about the human PBMC xenograft GvHD model. So in this model, I'll just focus on some of the key differences. We provide a sublethal dose of total body irradiation to aid in the engraftment of the cells. And then on day 0, we provide human PBMCs injected into NSG animals as the cells that cause disease. The number and donor of the cells can vary between studies, and I'll show data how that can affect disease severity. So while we've listed here treatment starting on day 14, we often start treatments earlier in this model based on severity of disease. So in this first graph here, just illustrates the differences of mortality when different levels of human PBMCs are introduced during the cell transfer. So the 3 groups here represent 5, 10, and 20 million human PBMCs injected on day 0. So as you can see here, animals in group 3 that receive the highest dose of PBMCs show a pretty rapid onset of disease with 100% mortality before day 21. And as you can see here, we see dose-dependent changes in disease severity with lower amounts of PBMCs. We've also often seen donor-specific responses within this model, so it's very important to validate each lot of donor cells prior to running this model. So in this specific graph, we show 2 different doses of PBMCs for 3 different donors, and as you can see, disease course severity is much different between the donors. So getting back to some of our standard metrics for the disease, we again see dose-dependent changes in weight change as human PBMCs number changes, as well as dose-dependent changes in the composite GvHD score as the number of human PBMCs change. So to summarize the models that we offer for graft versus host disease models, we have an acute GvHD model, which is a major MHC mismatch model, a sclerodermatous chronic GvHD model, which is a minor HA mismatch model, as well as a human PBMC xenograft GvHD model in which human PBMCs are injected into NSG hosts. I'd next like to transition to the pulmonary disease part of the talk. So we offer a number of pulmonary disease models, which I'll get into a bit further. Pulmonary disease is the 3rd leading cause of death in the world, and this includes diseases such as acute lung injury, COPD, acute respiratory distress syndrome, asthma, as well as idiopathic pulmonary fibrosis. And while treatments for these diseases exist, the need for better treatments and cures remain in high demand. And so today we're going to focus on a subset of these diseases and present data from models of acute lung injury and asthma. So we assess pulmonary diseases in a number of different ways. We look at lung mechanics and airway hyperresponsiveness. We look at bronchoalveolar lavage fluid, both the cellular components as well as cytokines within that fluid, as well as in lung tissue. And we often look at histopathology as well for the lung tissue. And the stains that we're using to assess disease will vary a bit based on the specific disease that we're looking at. And we're able to look at lung mechanics using a flex event. So a flex event is a mechanical ventilator that provides pressure volume measurements. And from these measurements, we're able to determine clinically relevant outcomes, including inspiratory capacity, lung compliance, lung elastance, as well as a number of other outputs. Additionally, we're able to administer aerosolized doses of methacholine to demonstrate an airway hyperresponsiveness phenotype in asthma models. Additionally, we have a device known as an expose, which allows for aerosolized drug delivery to mice and rats. It can deliver drugs to up to 12 mice at a time or 4 rats at a time. Benefits of using this device include low internal volumes, which means that less drug is needed, and ingestion opportunities are limited when comparing to a large open chamber aerosol device. So I'd first like to give a little background on asthma. So asthma is a chronic pulmonary Th2-driven disease. In this disease, we see airway narrowing and remodeling of the airways. And while mild and moderate asthma is well controlled with current treatments, more severe disease has more of a challenge in treatment. And so severe asthma profiles are often characterized as a mixed neutrophilic, eosinophilic asthma. And in these, we see that Th1, 2, and 17 pathways are all activated. So today we're going to speak about 3 specific models of asthma, one being an ovalbumin-induced model, another being a house dust mite-induced model, and finally another version of a house dust mite model that shows a more severe allergic asthma mixed phenotype. So as I kind of gone over before, we're going to talk a little bit about the data that we typically get from these models, including differential cell counts from the bowel fluid, lung mechanics, as well as histopathology and cytokine analysis. And so first I'll start with showing data from the ovalbumin-induced model. So here's an example of a typical study design for the OVA-induced allergic asthma model. Again, with the control groups that we typically run in the model, one being a small naive group, a diseased vehicle-treated group, as well as a diseased group treated with a reference compound. For disease induction, we'll administer ovalbumin with aluminum hydroxide by intraperitoneal injection on both day 0 and 7. We'll then challenge the animal with an intranasal delivery of ovalbumin on days 13, 14, and 15, and then look at endpoints on day 16. So the first set of data I'm presenting here demonstrates the airway hyperresponsiveness phenotype. So as increased doses of methacholine are aerosolized and applied to these animals, you see increases in both lung resistance and elastance. And this is more exaggerated in the asthmatic animals. We're also able to show here that with dexamethasone treatment that we see a beneficial effect on both lung resistance and lung elastance. Additional data for this model includes analysis of bronchoalveolar lavage fluid. So as you can see here, in asthmatic animals, we see increases in total cells and total eosinophils, and with dexamethasone treatment, see a substantial drop in those cell types. When looking at lung histology in these asthmatic animals, we see that mixed inflammatory cells are highly upregulated in these lungs, and that with dexamethasone treatment, we have a return closer to the naive phenotype. The next model that I'll present data from is from a house dust mite-induced allergic asthma model. So the one big difference in this model, other than having a different allergen, is a more physiological route of exposure. So in this model, we provide HDM intranasally on both day 0 and 7 without an adjuvant, and then challenge intranasally again on day 14 and on day 15, looking at all the similar endpoints. So in this first slide, we're looking at lung tissue that's stained both by H&E as well as PAS. And so while we see nice lungs in the saline control samples, we again see this mixed infiltrate in the HDM sensitized and challenged animals. And in the PAS slides, we see goblet cell hyperplasia in the diseased animals as well. So these animals also display an airway hyperresponsiveness phenotype. And as you can see, treatments with dexamethasone and fluticasone provide benefit to that readout. Then looking at the bronchoalveolar lavage fluid, we see increases in both total cells, eosinophils, and neutrophils. And then treatment with dexamethasone causes substantial drops. Also looking at Th2 cytokines, we see significant increases in the asthmatic animals, and treatments with both dexamethasone and fluticasone bring these levels back towards baseline. And so the final model that I'll speak about is severe allergic asthma model induced with house dust mite allergen. So in this model, house dust mite allergen is given with complete Freund's adjuvant on day 0 as a subcutaneous injection. These animals are then challenged intranasally with HDM on day 14, and responses are looked at 2 days later on day 16. And as you can see, these animals demonstrate an airway hyperresponsiveness phenotype and show increases in inflammatory cells as well as goblet cell hyperplasia in lung histopathology. Looking at the bowel fluid in these animals, we see significant increases in total cells, total eosinophils, as well as total neutrophils, and see increases in both Th2 as well as Th1 cytokines. So to review, we spoke about ovalbumin and house dust mite-induced acute allergic asthma models, as well as a severe HDM-induced allergic asthma model. And the final disease category that I'll talk about today is acute lung injury. So this is a disease characterized by hypoxemia, pulmonary edema, low lung compliance, and widespread capillary leakage. This often is seen in pneumonia, sepsis, aspiration, as well as trauma. And in humans, this usually requires mechanical ventilation, which can increase the risk of ventilator-induced lung injury. So we have a couple different models of acute lung injury that we run here at BioModels, and today I'll just be focusing on the LPS-induced lung injury model. We show similar endpoints here to that of the asthma model, including bronchoalveolar lavage fluid analysis, lung mechanics, as well as histopathology. And so in this model, again showing the control groups, we have a small naive group, a diseased vehicle-treated group, as well as a reference compound disease-treated group. Animals are given LPS on day 0 intranasally, and endpoints are measured on day 2. So in this first piece of data, we see that in diseased animals, a shift downward in the pressure volume curve, indicating stiffer lungs. With dexamethasone treatment, we see overlap with naive animals, indicating return to baseline lung function. And from these pressure volume curves, you get a number of outputs, including tissue elastance. And as you can see here, in diseased animals, we see substantially increased levels of tissue elastance, and then with dexamethasone treatment, a return back to baseline. Additionally, in this model, we see increases in inflammatory cells in diseased animals, and in dexamethasone treatment results in substantial decreases in those cell levels. Additionally, looking at both IL-6 and IL-1 beta in the bowel fluid, we see large increases in diseased animals and substantial drops in dexamethasone-treated animals. And as a quick review, we have both LPS and hydrochloric acid-induced lung injury models. And that concludes my portion of the talk today. I'd now like to pass the microphone to my colleague Nicole to talk about inflammatory bowel disease models.
Thank you to my colleague Andrew and to scientist.com for hosting this webinar today. My name is Nicole Smith, and I'm a scientist at BioModels, and I'm happy to be here today to discuss rodent models of colitis and inflammatory bowel disease at BioModels. I'd like to start today with a brief discussion of the disease and a discussion of Crohn's disease and ulcerative colitis. And then I'd like to talk about current treatment strategies and what might be new and coming down the pipeline. And then I'd like to spend most of my time today reviewing the animal models of IBD and colitis that we have at BioModels, and talk about model selection, example study designs, go through disease progression, and introduce study endpoints that we have available. And then I like to spend a little bit of time talking about the microbiome and IBD and colitis, and what we have available for study design options. And then I will go through some closing remarks. So IBD is a spectrum of chronic gastrointestinal disorders. Both ulcerative colitis and Crohn's disease fall under this umbrella term. The cause of disease is often unknown, but multiple risk factors include diet, environmental factors, and genetic susceptibility, among others, have been implicated. IBD affects a large number of people, as greater than 0.7% of Americans and 0.3% of Europeans are diagnosed. So looking at ulcerative colitis, this is a disease that affects only the colon. Inflammation and ulcerations are restricted to the mucosa and the submucosa. But in Crohn's disease, any part of the intestine can be affected, but it's most commonly the terminal ileum. And we see areas of inflammation dispersed between healthy areas. And there may be extraintestinal involvement in areas such as the esophagus or the stomach. Current treatment strategies in the field involve a step-up approach, moving from antibiotics up to immunosuppressives and corticosteroids to biologics and to finally surgery as disease progresses from mild to moderate to severe. New treatment approaches currently in the pipeline involve targeting of the immune cell trafficking pathways with anti-adhesion agents and inhibition of specific cytokines and signaling pathways. As Andrew mentioned earlier, our goal at BioModels is to support preclinical programs with quality science to progress potential therapeutics to the clinic. So here I've highlighted a list of rodent IBD models that I'm going to be discussing today, moving from chemically induced models to models with immune-mediated induction methods. We do also have other models, which I won't have time to talk about today, including a germ-free IL-10 knockout model and the oxazolone-induced colitis model. Please feel free to reach out to us if you're interested in these particular models. We would be happy to discuss them in greater detail. So with all of our IBD models, we have standard readouts that we typically recommend, including body weight assessment, disease activity index scoring, diarrhea, and blood in the stool, endoscopy, which I'll talk about more in the next slide, also colon weight length ratio, and colon histopathology. We also have a full in vitro lab and can assess cytokine production, tissue and fecal myeloperoxidase production, and specific cell types and subsets of cells using flow cytometry. Custom assays are also possible, so don't hesitate to reach out to us to discuss any ideas that you might have. Before I get into the model data, I'd like to talk about a unique capability that we have at BioModels, which is video endoscopy. And this is performed under isoflurane anesthesia, and it allows for longitudinal assessments in a single animal. We do collect photos and video at the time of the procedure, and each animal is scored on a 4-point scale ranging from normal through loss of vascularity to friability and all the way up through ulcerations and active bleeding in most severe cases. So the first model that I'd like to discuss is the acute model of DSS-induced colitis. Here we have a typical acute DSS study design where animals are exposed to DSS in the drinking water from day 0 through day 5. Treatment strategies can include both prophylactic and therapeutic schedules, depending on the study goals and the test treatment requirements. Some common readouts that I mentioned previously include DAI scoring and endoscopy. And the animals are euthanized on day 19 and tissues are collected for endpoint analyses. So in this model, mean body weight decreases after removal of the DSS treated drinking water and typically peaks on day 8 or day 9, followed by body weight recovery to near baseline levels by the conclusion of the study. Here we're showing a day 12 endpoint, but the colitis does remain robust in the model through day 19. With anti-IL-12p40 treatment, we typically see a significant improvement in body weight loss compared to the vehicle control group, whereas other treatments such as tofacitinib don't have the same effect on weight loss. We see a significant increase in composite DAI scoring in the DSS-treated vehicle group compared to the naive control animals, and a significant decrease in composite DAI scoring when animals are treated with anti-P40. And also a trend towards a reduction in scoring when animals are treated with tofacitinib. And looking at the terminal colon weight length ratio, DSS results in significant increase in the ratio compared to the naive animals by day 12, but no improvements with reference compounds were observed at this particular time point. Depending on your study goals, you may choose to terminate the study on day 12, for example, to assess disease readouts or biomarkers near peak colitis, or you may choose to extend the study to day 19 to assess test treatment efficacy over a longer window of time. Colitis severity and stool scoring consistency are evaluated by endoscopy, typically near peak disease, as shown here, and also at the termination of the study. Significant increases in both colitis severity and stool consistency scoring are observed with DSS treatment, and decreases in both metrics are observed with anti-P40 treatment. Histopathology on the colon tissue is also commonly performed to assess multiple parameters such as inflammation, necrosis, erosion, edema, and epithelial hyperplasia, which makes up the sum score as seen below. Here we have a significant increase in the sum score with DSS exposure. When we look at cytokine expression in the colon tissue by multiplex, we see a significant increase in key pro-inflammatory cytokines like IL-1 beta, IL-6, and TNF alpha, among others. As I mentioned before, we do have a full in vitro lab and are able to analyze cell types and subsets of cells via flow cytometry in various tissues. In the acute model of DSS, disease induction results in a significant increase in neutrophils in the spleen, mesenteric lymph nodes, and in the colon lamina propria. Taken together with the colon cytokine data, DSS colitis induction results in multiple sites of immune activation. Moving to the chronic DSS-induced colitis model, we have disease induction using 3 cycles of DSS as shown here. The treatment window for reference compounds and test treatment is flexible, and the study typically terminates on day 35. Body weight loss in the model typically begins following the second cycle of DSS with reference compounds such as prednisolone, cyclosporin A, and 6-thioguanine providing little benefit. Peak colitis, as assessed via endoscopy, is seen after the second cycle of DSS around day 20. Colitis remains consistent through the end of the study, where improvements in scoring with reference compound treatment can be observed on day 34. The longer study duration here allows for extended test treatment dosing. Another very common chemically induced model of colitis is the TMBS model. Colitis is induced through an intrarectal administration of TMBS in 50% ethanol. Here, the study duration is short, ending on day 4, but allows for fast screening of test treatments. And because the model is short, we do recommend prophylactic dosing. Another important note is that we don't have any consistently effective reference compounds that we can recommend in this particular model. In C57 black 6 mice, treatment with TMBS results in body weight loss, which typically peaks on day 1 or day 2, followed by mild body weight recovery by the end of the study. And here we also have a significant increase in diarrhea incidence observed. Endoscopic evaluation on days 2 and 4 show a significant increase in both colitis and stool consistency scoring when mice are treated with TMBS, with peak colitis severity typically observed on day 2. As in the DSS model, colon histopathology is also commonly assessed and does correlate well with other in-life readouts. We also have a model of TMBS-induced colitis in bulb C mice. Here, survival is affected by TMBS treatment, and the study duration is extended due to the inherent increased susceptibility of the animals compared to the C57 black 6 mice. Peak body weight loss is observed between days 2 and 4, followed by a modest recovery. Significantly increased colitis severity scores are seen on days 4, 7, and 10, with the peak occurring on day 4, and a significant increase in the colon weight length ratio is observed at study termination. Now, moving into the immune-mediated induction models, the next model that I'd like to discuss is the CD40 monoclonal antibody-induced colitis model. Colitis is induced in RAG2 knockout mice using a single injection of CD40 monoclonal antibody on day 0. Disease is followed through day 7, and the short duration of the study here also allows for efficient screening of test treatments. Some commonly used reference compounds in the model include anti-TNF-alpha and anti-P40. And consistent and robust disease induction is seen in the model with body weight loss peaking between days 3 and 7. Treatment with both anti-TNF and anti-P40 are effective in significantly improving body weight loss compared to the vehicle control, while treatment with another commonly used reference compound, tofacitinib, did not provide any benefit here. Peak disease by endoscopy is observed on day 3, with colitis persisting through day 7. Treatment with anti-TNF-alpha, but not anti-P40 or tofacitinib, results in a significant reduction in colitis severity compared to the vehicle control group. And again, colon histopathology can be used to get a more granular view of the affected tissue. Following a similar trend to the other in-life readouts, treatment with both anti-TNF-alpha and anti-P40, but not tofacitinib, results in a significant reduction in composite DII scoring compared to the vehicle control group. No major differences in the terminal colon weight length ratios are observed with reference compound treatment compared to the vehicle control group. When we look at cytokine expression in the colon tissue, we see an induction in key pro-inflammatory cytokines with CD40 monoclonal antibody treatment. And again, treatment with anti-TNF-alpha and anti-P40 significantly reduces that expression. The last model that I'd like to discuss today is the naive T-cell transfer-induced colitis model. Here, colitis is induced through the injection of donor naive T helper cells into recipient mice on day 0. On day 13, flow cytometry is performed to assess T-cell engraftment, and animals are randomized into treatment groups. And this is typically when test article treatment also begins. The model is responsive to the reference compounds that I talked about previously in the CD40 model, anti-TNF and anti-P40. So just to give a brief overview of the model approach, splenocytes are harvested from donor C57 Black 6 mice. Naive T helper cells are isolated and then injected into RAG2 knockout recipient mice. CD62L positive, CD44 negative naive T helper cells are isolated using a magnetic negative selection cell sorting process. Disease typically develops 3 to 5 weeks post-cell transfer. Body weight loss begins around day 21 and progresses over the course of the study. Survival is also affected and serves as a key readout in this particular model. Here, we can see that treatment with anti-TNF-alpha, but not anti-P40 or tofacitinib, results in a reduction in both body weight loss and mortality compared to the vehicle control group. Treatment with anti-TNF-alpha also results in reduction in composite DAI scoring, but does not affect the colon weight length ratio. When we look at colitis severity in this model, the overall scoring is lower compared to what we see in the chemically induced models, but we do see increased severity over time, and by day 42, we see significant reduction in colitis severity with anti-P40 treatment compared to the vehicle control group. In the colon histopathology, we also see significant immune cell infiltration. At day 42 in the model, an increase in select pro-inflammatory cytokines is observed, as well as a significant increase in the colon lamina propria CD4 positive T cells as assessed by flow cytometry. Before I conclude today, I'd like to talk briefly about the role of the microbiome in IBD. A lot of recent research has clearly demonstrated that there are certain species of bacteria that are increased and decreased in specific disease states like Crohn's disease and ulcerative colitis. We know that this balance is very complex and that microbial dysbiosis can lead to not only IBD, but other diseases such as autoimmune diseases, allergic conditions, and metabolic diseases. So how can BioModels help you address your microbiome-related questions? So we have multiple levels of housing and handling and husbandry available, ranging from conventional to germ-free. We have a lot of experience in the design and execution of studies that manipulate the microbiome, such as bugs as drugs, or targeting of the microbiome to reduce inflammation in subsequent pathology. And we also have experience with utilizing humanized microbiome. So with that, I would like to summarize what we've talked about today. So in part one, you heard about acute, chronic, and xenograft models of GvHD, also acute and severe models of asthma, as well as acute lung injury models that we utilize at BioModels. In part two, I talked about multiple IBD induction strategies, as well as how models can be chosen based on study goals and test treatment targets. And we have a wide variety of standard and additional readouts available. And we have a lot of experience and are able to address the role of the microbiome in IBD as well. So with that, I'd also like to mention that I'd like to conclude today's presentation, and I'd like to mention that we work in a variety of other disease areas in addition to those discussed today. If you don't see what you're looking for here, we'd be happy to discuss the possibility of setting up a custom model as well. I also like to mention that we do have a full in vitro lab, which I talked a bit about during the presentation, and we have additional in-life monitoring and surgical capabilities. So getting a project started with us is very straightforward. If you're on scientist.com, you can submit a project request and we'll get back to you. If you're not on the platform, you can contact us via email or through our website, which will be provided on the next slide. And a breakdown of the 6-step process is shown here. From initial contact to delivery of the final report, we offer the total solution from start to finish. We hope to have the opportunity to collaborate with many of you in attendance today. So with that, I'd like to thank you again for joining our webinar today and to scientist.com for hosting. And please feel free to reach out to us with any questions or to discuss any potential projects.
Thank you, Andrew and Nicole, for those fantastic presentations. Unfortunately, we don't have time remaining to answer questions in today's live session, but it is certainly not too late to submit them. Please continue to send them in via the Q&A panel or on the survey, and our presenters will respond directly to you in the coming days. Thank you once again to Andrew and Nicole for sharing all of your insights today. It's been a pleasure having you with us. A big thank you also to our audience for participating. And last but not least, we'd like to thank the sponsor of today's webinar, BioModels. We now invite you to take a moment to share your feedback on the survey. We do read all of your comments and appreciate your input. As mentioned, if you still have a question, it's not too late. Feel free to send it in now and we'll forward it along to Andrew, Nicole, and the BioModels team following the event. And if you're interested in learning more about the research, we invite you to check out the resources panel. In closing, we hope you enjoyed the scientist.com and BioModels webinar, and we hope to see you again next time.